Hello everyone, today the topic which we're gonna study is a rheumatoid arthritis. So what's rheumatoid arthritis? It is a chronic autoimmune inflammatory, destructive and deforming polyarthritis. It is characterized by the bilateral symmetrical involvement of a small and large joint with systemic involvement and extra articular feature having prolonged course with intermittent exacerbation and remission. It means that in a short, the rheumatoid arthritis is an autoimmune condition involving joint and other system of a body having prolonged intermittent exacerbation and remission. So what's the etiology of rheumatoid arthritis? Rheumatoid arthritis is the most common in a female. It occurs at the age group of 30 to 50 years. It is 3 times more common in female. But after menopause, the sex ratio became equal. Mean that after menopause, the involvement of rheumatoid arthritis in male and female get equal. Now coming toward the clinical feature of rheumatoid arthritis. As the rheumatoid arthritis is an autoimmune disease, so along with joint it will involve the multisystem of a body. So for this instance, the clinical features are divided into the articular manifestation and extra articular manifestation. So the first we will discuss the articular manifestation, and after that we will study the extra articular manifestation of rheumatoid arthritis. So what are the articular manifestation of rheumatoid arthritis? It causes symmetrical joint inflammation. It is gradual in onset. It causes pain, stiffness and swelling. The classical representation of rheumatoid arthritis is a morning stiffness which lasts more than an hour and it improves with use. It most commonly involves the wrist and hand joint. In hand, it involves the PIP, the proximal phalangeal joint, and MCP, the metacarpophalangeal joint. Remember that the DIP joint and the lumbar spine are spare in a rheumatoid arthritis. It is in contradictory with osteoarthritis, which involves both DIP joint and the lumbar spine. The rheumatoid arthritis causes a characteristic deformity of a hand. This characteristic deformity results from a chronic synovitis. Due to chronic synovitis, there will be a bone erosion which will lead to a pathological joint deformity. These joint deformity include a first one is a swan neck deformity. The swan neck deformity you can see in a first image. In swan neck deformity, there is a hyperextension of a PIP joint and there is a flexion of a DIP joint. The second one is a Boutinnare deformity. In the Boutinnare deformity, there is a flexion of a PIP joint and the extension of a DIP joint. It is an opposite of a swan neck deformity. The third one is ulnar deviation. In the ulnar deviation, the hand turned toward the ulnar side of a hand. The last one is a Z thumb. In the Z thumb, due to a synovitis and a erosion of a tendon, the thumb attain a shape of a Z. So it is called as a Z thumb. The Z thumb can be illustrated in the last image. You can see the thumb attain a Z shape. After hand, now come toward the axial spine. The axial spine is usually spare in rheumatoid arthritis. It is in a contradictory with osteoarthritis, which involves the axial spine, except at the cervical region C1 and C2, which is a atlantoaxial joint. The long-standing rheumatoid arthritis involves the atlantoaxial joint. It can cause neck pain and stiffness initially, but later it can cause a cervical subluxation. Due to the cervical subluxation, it causes a life-threatening spinal cord compression. So it requires a surgical treatment, and the cervical spine involvement can be limited by the Dmards. So it is very important to have an prior X-ray neck of a patient of rheumatoid arthritis who is undergoing a GI or any surgical or intubation process, because if there is an involvement of an atlantoaxial joint, there will be a cervical subluxation, there will be a life-threatening spinal cord compression, due to which a patient can die on a surgical bed. So it is important to have an X-ray neck of a patient prior to any surgical procedure. Next articular manifestation of rheumatoid arthritis is a Baker's cyst. The Baker's cyst is a swelling of the gastrocnemius semimembranous bursa. It is present at the back of knee. It communicates with the knee joint, but the fluid is prevented from going back to the knee because of a valve-like mechanism. During the flexion of a knee joint, it can rupture, so the fluid can enter into a calf. So it can cause a severe pain and tenderness. Most oftenly, the ruptured Baker's cyst is confused with DVT. In order to differentiate a Baker's cyst from a DVT, the deep vein thrombosis, the diagnostic tests which are performed are the ultrasound of a knee joint, CT scan, MRI, and the arthrogram. For the treatment, the first line therapy is an NSAID which is used for a pain relief. We can also cause an elevation of a limb. It will also give a symptomatic relief. We can also give an intra-articular injection of a steroid. And the last resort is a surgical toitling and the removal of the cyst. So it will cure a Baker cyst. By now we are done with an articular manifestation of a rheumatoid arthritis. Now we will study the extra articular manifestation or the systemic manifestation of rheumatoid arthritis. It can involve any part of a body. The first one is a cardiac. In cardiac, it can cause a pericarditis, pericardial effusion, conduction abnormality, and valve incompetence. In pulmonary system, it can cause a pleural effusion and the interstitial fibrosis. It can also involve an eye. The ocular involvement manifests as an episcleritis and a scleritis. It can also cause the anemia of a chronic disease which is a normochromic normocytic anemia. It can cause a carpal tunnel syndrome. It can cause a Sjogren syndrome. It can lead to a muscle wasting and the osteoporosis. Remember that along with articular and the extra-articular manifestation, it can also cause a generalized symptom such as a weight loss, fatigue, and malaise. Extra-articular manifestation of a rheumatoid arthritis is a rheumatoid nodule. Rheumatoid nodule are the painless, firm subcutaneous nodule, which you can see in this image. It is a pathogenomic for a rheumatoid arthritis. It presents in 20 to 30% of a patient. It represents the active and aggressive disease. It is a bad prognostic sign. Mean when patient have a rheumatoid nodule, the treatment of a rheumatoid arthritis get difficult. It usually resolves when the disease is under control. Usually there is no treatment required for rheumatoid nodule, but for a cosmetic appearances we can surgically remove the nodules, or we can give a local steroid injection which will resolve the rheumatoid nodules. By now we are done with the clinical feature of rheumatoid arthritis, which involve both the articular and extra-articular system. Now coming toward the diagnosis of rheumatoid arthritis. Remember that there are different criteria for diagnosing rheumatoid arthritis. Here we will study the American College of Rheumatology criteria for rheumatoid arthritis. It involves 7 criteria and 4 should be met to confirm the diagnosis of rheumatoid arthritis. It includes a morning stiffness greater than 1 hour, arthritis of a hand and wrist joint, arthritis of a 3 or more joint, symmetrical arthritis, rheumatoid nodule, positive rheumatoid antigen and ACPA, and the typical radiological findings such as erosion and the periarticular osteopenia. Remember that all these 7 clinical features should be present for 6 weeks or more than 6 weeks. When these clinical features are present for 6 or more than 6 weeks, it will confirm the diagnosis of rheumatoid arthritis. Now let's study this criteria in a bit detail because it's most often came in exam. So the patient of rheumatoid arthritis should have a morning stiffness which should last more than 1 hour. If the morning stiffness lasts less than 1 hour, it's very unlikely to have a rheumatoid arthritis, and the stiffness improve with work. The second one is that the patient should involve hand and wrist joint, and the patient should have a polyarthropathy such as it involve a more than 3 or more joint. Remember the term monoarthritis, oligoarthritis, and the polyarthritis. Monoarthritis means that the patient should involve one joint. Oligoarthritis means that the patient should involve 2 to 3 joint, and the polyarthritis means that the patient should involve more than 4 or more than 5 joint. So the rheumatoid arthritis is a polyarthritis, so it should involve more than 3 joint. The patient should also have a symmetrical arthritis. Symmetrical arthritis means that the both side of a joint should involve. For example, if a knee joint is involved, the right and left both knee will be involved simultaneously. There will be also a rheumatoid nodule which is a pathogenomic for rheumatoid arthritis. The patient should also have a positive rheumatoid antigen and ACPA, which we will study in a next slide, and the patient should have a typical radiological finding such as the erosion and the periarticular osteopenia. Now we will study the 2 most important diagnostic tests used for the rheumatoid arthritis. The first one is a rheumatoid factor. What is the rheumatoid factor? The rheumatoid factor is an antibody directed against the Fc portion of an IgG. It can be the rheumatoid factor can be an IgG or it can be an IgM. It is positive in about 75% of cases. It is associated with disease severity. The rheumatoid factor is have high sensitivity, but it lacks specificity. Because the rheumatoid factor is positive in other diseases, include collagen disease such as Sjogren and SLE, in infections such as infective mononucleosis and infective endocarditis. It is also positive in the liver diseases and sarcoidosis. And remember that the rheumatoid factor are positive in a normal population who are above 65 years of age. Roughly about 20% of population above 65 years of age have positive rheumatoid factor. The next most common diagnostic test performed for the rheumatoid arthritis is the anti-citrullinated peptide antibody, also called as an anti-ccp antibody. It is an antibody to a cyclic citrullinated peptide. It binds to a peptide citrulline. What is a citrulline? Citrulline is a peptide which is produced from an arginine in inflamed synovium. Remember that in inflamed synovium there is a high amount of an enzyme peptidyl arginine deaminase. This enzyme will convert the arginine to acetylcholine, and the anti-citrullinated peptide antibody will bind to a citrulline. This test is highly specific. Its specificity is about 90%. It is helpful for the early diagnosis, and it can detect even an asymptomatic patient of a rheumatoid arthritis. Other tests which can be performed in rheumatoid arthritis are the CBC. The CBC will show a normocytic, normochromic anemia. The ESR will be raised, the CRP will be raised, and there will be a radiographic findings such as erosion and the periarticular osteopenia. Coming toward the treatment of a rheumatoid arthritis. The aim of a treatment in rheumatoid arthritis is to minimize pain and swelling, to prevent the disease progression, and to maintain patient functionally well. Remember, for a symptomatic treatment such as pain and swelling, NSAID are the drug of choice. The second line therapy is the corticosteroid, but remember that the low dose corticosteroid can be used, and it can be only used when the NSAID don't provide an adequate relief. And remember that we should avoid the long-term treatment with the steroid because the steroid adversely affect the bone and joint. So it can be only used for a pain relief. Now coming toward the drug of choice for the rheumatoid arthritis, these are the Dmards, disease-modifying anti-rheumatic drugs. These drugs reduce the morbidity and mortality by 30% in the rheumatoid arthritis patient by limiting complication and the progression of a disease. They should be initiated as early as possible. They have a slow onset of action. So they can be used initially with NSAID and steroids. So once the function of a Dmard get evident, we taper the dose of NSAID and the steroids. First line Dmard used for the rheumatoid arthritis is a methotrexate. Methotrexate is a first line Dmard. It shows the initial improvement in 4 to 6 weeks. But remember that the methotrexate are highly toxic, so watch for a GI upset and ulcer, bone marrow suppression which can lead to agranulocytosis. It can also cause a hepatocellular injury and can cause a pulmonary fibrosis. So remember, when we put a patient on a methotrexate, we should do a regular monitoring for renal and liver function. Also remember that we should supplement a methotrexate with a folic acid because the methotrexate interrupt the metabolism of a folic acid, so patient will have a deficiency of folic acid. So to prevent the deficiency of folic acid, we supplement a patient with folic acid who are on a methotrexate. Apart from the methotrexate, other Dmards can also be used. It includes a sulfasalazine. It is also a first line therapy, but it is less effective than methotrexate. The hydroxychloroquine can also be used. It is a first line therapy, but it can cause a retinal toxicity. So when we put a patient on a hydroxychloroquine, we advise them to have an eye examination every 6 monthly. We can also use a leflunomide. It uses as an adjuvant therapy with methotrexate. Remember that initially we use a 1 Dmard, but when the patient show no improvement, we add a 2 Dmards. But when the 2 Dmards are not showing appropriate benefit, we add a biological Dmards. These are the agent which block a specific immune receptor. They are highly expensive, so they can be only used when the 2 Dmards are failed. It include an anti-TNF alpha, interleukin 1 receptor, interleukin 6, and the rituximab. The anti-TNF alpha are more effective, rapid acting, and have a greater clinical efficacy. It includes an infliximab, etanercept, and the adalimumab. Remember, by a mnemonic AEI. Its side effects include a hypersensitivity, headache, and hypotension. It can also cause a reactivation of a latent tuberculosis and sometimes can cause a lymphoma. The interleukin 1 receptor include an anakinra. It can be used in the rheumatoid arthritis when the anti-TNF alpha is unsuccessful. It is used in a combination with methotrexate. The interleukin-6 include tocilizumab. It is a humanized monoclonal antibody against the interleukin-6 receptor. It is used in a moderate to a severe arthritis in an adult patient. Last one is the rituximab. The rituximab is an anti-CD20 antibody and it can be also used in a patient with a rheumatoid arthritis. We will study a remission criteria. The remission criteria mean that how the patient is responding to a therapy. So it includes a no joint pain, no fatigue, no joint tenderness, morning stiffness which should last less than 15 minutes, no soft tissue swelling and ESR less than 30 mm in 1 hour. If the 5 of the 6 criteria are met for at least 2 consecutive months, we say that the patient have a remitted from a rheumatoid arthritis. So we can reduce a therapy and we can say that we have almost controlled a rheumatoid arthritis. We will conclude our discussion by studying a few syndromes which are associated with the rheumatoid arthritis. The first one is the Caplan syndrome. The Caplan syndrome is a rheumatoid lung nodule with a pneumoconiosis. It is most common in a cold worker. There are nodules which are formed at the periphery of a lung, which are about 0.5 to 2.5 centimeter. These nodules may rupture, causing a pneumothorax, or these nodules can cavitate, causing a hemoptysis. Remember that these nodules may be sometimes confused for the tuberculosis, so we should rule out this condition. The second one is the felty syndrome. The felty syndrome is a rheumatoid arthritis with splenomegaly and the neutropenia. In this, there is a hypersplenism which will lead to anemia, leukopenia, and the thrombocytopenia. It most commonly occur in a female about 50 to 70 years of age, and it can also cause a leg ulcer or sepsis due to a neutropenia. So to treat this, we sometimes perform a splenectomy. The last condition associated with the rheumatoid arthritis is the palindromic rheumatoid arthritis. It is a recurrent acute episode of a monoarthritis which lasts for about 24 to 48 hours. It includes knee and finger joint, but it can include any peripheral joint. It is associated with fever, but other systemic signs are absent in palindromic rheumatoid arthritis. So it can be confused with a gouty arthritis. So it is a special kind of rheumatoid arthritis we should take in consideration. For the treatment, we can use a NSAID for the acute attack of pain, and to prevent the recurrent attack, we will use a hydroxychloroquine. So it's marked the end of a rheumatoid arthritis. If there's still any question, you guys can ask and stay tuned for a more update.